The Best of ASCO meeting provides exclusive access to and analysis of the most impactful and clinically scientific content from the ASCO annual meeting, so you can take home practical insights that will enhance patient care. Join us July 19th through 20th in Boston or online. Register today at boa.asco.org.
Hello and welcome to the ASCO Daily News Podcast. I'm Dr. Shaalan Beg, your guest host of the ASCO Daily News Podcast today. I'm an adjunct associate professor at UT Southwestern's Harold Simmons Comprehensive Cancer Center in Dallas. On today's episode, we'll be discussing the emergence of circulating tumor DNA, or ctDNA technology in GI cancers. I'm delighted to be joined by Dr. Aparna Parikh, an assistant professor of medicine at Harvard University and the director for colorectal medical oncology at the Mass General Hospital Cancer Center, where she also serves as the medical director of the Young Adult Colorectal Cancer Center. Dr. Parikh will share her insights on key research on this hot topic in GI oncology that was featured at the recent ASCO Gastrointestinal Cancers Symposium. Our full disclosures are available in the transcripts of this episode, and disclosures related to all episodes of the podcast are available at asco.org/dnpod. Dr. Parikh, it's great to have you on the podcast today.
Thanks so much, Dr. Beg.
So, recent years, it's become evident that liquid biopsy and other emerging ctDNA technologies are changing how we treat GI cancers, and colorectal cancer is in the forefront of this space. And before we dive into key studies, can you briefly highlight to our listeners how ctDNA is advancing the field and how it can influence the care that we deliver to our patients in the future?
Absolutely. So ctDNA is certainly a hot topic. What we have learned over the years is that ctDNA has really emerged, across many solid tumor types as one of the most powerful, if not the most powerful, prognostic biomarker we have to date. ctDNA has improved risk stratification. We have learned a lot about the role in what is called minimal or molecular residual disease in patients with early stage disease, and ctDNA being a biomarker of recurrence for those patients. With ctDNA, we have a better understanding of tumoral heterogeneity, both spatially and temporally, getting a better glimpse of what's happening in a given patient with multiple metastases, as well as genomic evolution of tumors over time. So certainly many, many roles and areas where ctDNA is emerging.
And this was a hot topic at the 2024 ASCO GI Cancers Symposium. So we're going to take a deep dive into some of the abstracts that were presented. And let's start with the COBRA study. That's the NRG GI005. That was abstract 5 on the ASCO GI Cancer Symposium, and the Galaxy study, which was abstract 6 at the symposium. So the COBRA study itself, it reported results of ctDNA as a predictive biomarker in adjuvant chemotherapy for people with colon cancer. And at a high level, it was a negative study, but there's some important lessons for us to learn. And similarly, in the Galaxy study, investigators from Japan presented an updated analysis on correlation of ctDNA dynamics with outcomes in colorectal cancer with minimal residual disease. How do you synthesize all this information and help the listeners understand what our current state is for ctDNA applications in colorectal cancer?
Yeah, so let's take COBRA first. The COBRA study, let's just talk a little bit about the design of COBRA. So COBRA was intended to look at patients that were resected stage 2 colorectal cancer patients or colon cancer patients who were 2A. And those are patients where the treating physician would at the outset decide that there was no adjuvant chemotherapy indicated. So these are patients where active surveillance would be entirely appropriate as standard of care. So patients were randomized to arm 1, which was active surveillance, or randomized to arm 2, which was assay-directed therapy. If there were ctDNA positive in arm 2, then they were given chemotherapy, FOLFOX or CAPOX. And if they were ctDNA not detected, then they would also go on to active surveillance. And so the plan was nearly 1,500 patients to be recruited. And at the time of this data cut, they had around 630 some patients. And the primary objective was to look at the clearance rates of ctDNA between the ctDNA positive cohorts. Remember, the chemotherapy and the active surveillance cohorts at 6 months. They had, around a 5% detection rate of ctDNA patients. And so that ultimately was around kind of 16 patients. And the reason that the study shut down was that what they found was actually in the surveillance arm, so the arm that was not getting any treatment, they had a ctDNA clearance of 43% versus in the chemotherapy arm of 11%. They had an interim analysis actually to look at that clearance rate between the two arms. And what was surprising to the investigators and the community was what was happening in terms of clearance. Why did we have a 43% clearance rate in patients that were not getting anything? And so because of that, the study, was shut down because it didn't meet its pre-specified interim look at clearance in those two arms. And many things came up in terms of learnings from COBRA. So number one was, I think, the characteristics of the assay. And so you take an assay in a low-risk patient population that has a fixed specificity. And when your baseline prevalence of recurrence is so low, and i.e. in a low-risk stage 2 patient, your composite predictive value is very susceptible to small changes in that specificity. And so your PPV is going to be a lot lower in a low-risk patient population than a higher-risk patient population. And the COBRA study used an older version of a tumor uninformed assay. So definitely called into question some characteristics of the assay. Is, one time point clearance sufficient? And is that the right endpoint? We have seen now from including the Galaxy study that we'll talk about here, previously reported just spontaneous clearance happening in 5 to 10% of patients. And the question with that spontaneous clearance, is it actually clearance, or, was chemotherapy or perhaps just in a low ctDNA shedding state? Are you just suppressing the ctDNA below the level of limit of detection? And in this study, the clearance draw was actually done in the chemotherapy arm right before the last cycle of chemotherapy. Again, to that point of, are you just suppressing the ctDNA with chemotherapy? There's also just sort of stochastic sampling error that can happen in patients with very low residual tumor volume. So, I think this is a disappointing study in the sense that it's still a really important question. There are still 2A patients that recur, but maybe not the right test, or, maybe single time point testing wasn't enough. And so lots of lessons to be learned from this study in terms of kind of test and design, but hopefully more to come. And I think certainly stage 2 patients remain an area where I think hopefully ctDNA will still be able to play a factor for those patients.
And how was the patient population for the Galaxy study, that's abstract 6, compared to the COBRA study? And could you summarize those findings for us?
Yeah, so Galaxy was part of a large study in Japan that includes an observational cohort plus therapeutic cohorts as well. And so Galaxy was just further reporting the observational cohort. So unlike COBRA, which is that low risk stage 2, that was actually asking that interventional question, can you use it to guide therapy? The Galaxy and the updated Galaxy just continues to show more clinical validity data rather than clinical utility data. And it was, nearly 3,000 patients, pan stages. Again, the lion's share were stage 2 and stage 3 patients, but there were stage 1 and stage 4 patients as well. And what they showed was that, again, ctDNA is undoubtedly prognostic. They showed very consistent Kaplan-Meier curves in what we've seen time and time again, where if you're ctDNA positive, you don't do as well. What they showed was, not surprisingly, with longer-term follow-up, this was 24-month follow-up, so longer-term follow-up than was published in their paper last year, was that when you test at one time point, so landmark testing, the sensitivity of detecting recurrence was around 48%, and that fell from the publication last year, which was around 58, 59%, which isn't surprising as you follow more people. I think single time point testing soon after surgery, may miss those late recurrences, but it's still prognostic, showed a specificity of around 94%. They also continued to show that if you continue to test with serial testing, your sensitivity improves. But what was really, I think, interesting and new, what they presented this time was a clearance analysis and showing, again, comparable to COBRA in many ways in the sense that clearance can be a little bit finicky, especially at one time point, is what they showed is that patients that had sustained clearance, and this is a patient that had at least 2 time points where their ctDNA remained to be negative, they did very well. But if you had transient clearance, and again, the definition was a little bit broad, but at least having 1 negative and then 1 positive, those patients actually, ultimately at 24 months, the curves came together with the no clearance curve. So initially they did better than the people that didn't have any clearance. But if you transiently cleared again at 2 years, the curves came back together. And, what was interesting is that in those patients that sort of transiently clear, by 9 to 12 months, like 80% of those are actually having a rapid return of ctDNA. And so again, sort of begs the question of, was chemotherapy, just suppressing that ctDNA, or, maybe if you had a better test, you could have actually improved it. Those were sort of the updated, interesting learnings from Galaxy. Just remains to be incredibly prognostic, and then this concept of clearance, which I think we have to look into a little bit more as a field, and understanding that maybe just 1 time point clearance isn't sufficient.
Yeah, and one of the most important applications for ctDNA can be its ability to inform adjuvant chemotherapy. So its ability to not only identify more people who may benefit from chemotherapy, but maybe even identify people who don't need chemotherapy. And along those lines, Abstract 9, the BESPOKE study, looked to understand the role of ctDNA-based detection of molecular residual disease to inform adjuvant therapy for stage 2 and 3 colorectal cancer. And they presented interim data at GI ASCO this year. What were your takings from this study?
Exactly. Like beyond, again, the prognostic implications, I think what was really interesting there was the initial data looking at that benefit of adjuvant chemotherapy. And so what they did was they said, okay, we're going to take the MRD positive patients and look at the benefit of adjuvant chemotherapy, and then the benefit of adjuvant chemotherapy in the MRD negative patients. And again, remember, this is a prospective observational study. So it's not looking at negative and positive to guide therapy, but it's just looking prospectively and observationally how those patients are doing. But what they showed again is that indeed in the adjuvant chemotherapy group, the benefit of adjuvant chemotherapy, again, with the follow-up to date on the study, was different in the MRD positive patients. And so the 2-year sort of DFS in the, first of all, I guess taking a step back, the DFS in the ctDNA negative patients at 2 years was very good. So negative patients, over 98% 2-year DFS in both adjuvant chemotherapy and observational group. And there's no really difference between adjuvant or not. But in the positive patients, that not surprisingly, the DFS is worse. But what was reassuring to see is that you can make an impact with adjuvant chemotherapy in the positive patients. And the difference in DFS between the positive and negative patients with adjuvant or not was, around 42% versus 12.5% in the observational patients. So it is benefiting the patients who are positive. So does give us more data that, again, at least in the positive patients, you can reverse, you may be able to truly reverse the recurrences there with adjuvant chemotherapy. And maybe if you're negative, eventually we'll get to a point of de-escalation of care, again, keeping in mind those kind of sensitivity limitations as well.
Wonderful. And one of the other malignancies in the GI space where precision therapies and molecular biomarkers are making a huge difference are intrahepatic cholangiocarcinoma. And genomic profiling using ctDNA is increasingly being used in this population to inform precision oncology approaches and determine mechanism of resistance to targeted therapies as well. In Abstract 5 to 8, investigators looked at the role of preoperative ctDNA testing for resectable intrahepatic cholangiocarcinoma. What are your thoughts on that study?
Yeah, so it's such an important area, I think, as you mentioned too, in the metastatic space, FGFR, IDH1, all these alterations that are emerging in the intrahepatic cholangios. So this was a very small study. So it was preoperative. So, the tumor is intact and, around 14 patients, and they used a tumor-informed approach just for detection and quantification of ctDNA. So this was not a study that was looking at, a next generation sequencing approach where you're going to be able to actually detect the alterations, but is actually looking for the detection and quantification of ctDNA rather than, genomic characterization. And patients, had about a month or so where they had their baseline blood detected. And I think what was reassuring to say was that ctDNA was actually detected in all the patients with the primary tumor intact, except for one patient that was a very low risk, was stage 1A patient. There was some correlation against small number of patients between the concentration of ctDNA in patients that had the lower stage and then the higher stage group. Small numbers, it was hard to actually characterize and correlate with recurrence or mortality, but at least some correlation with kind of pathologic tumor size. They were able to, because it's a bespoke panel and you're sampling the tissue and then looking in the blood, IDH 1 and 2 were mutations that were tracked based on the genomic profiling, and a couple of the patients were able to have their IDH mutations tracked. So it gives us a sense a little bit that, ctDNA, we know that it has a lot of variable shedding across disease states and tumor locations, but gives us some promise that it is reliably detected with the tumor-informed approach, at least preoperatively in cholangio, so may again open some more opportunities for MRD testing in cholangiocarcinoma as well.
Thank you. That's a wonderful review of ctDNA applications in gastrointestinal cancers from the 2024 ASCO GI Symposium. Thank you, Dr. Parikh, for sharing your valuable insights with us on the podcast today.
Thanks so much for having me.
And thank you to our listeners for your time today. You'll find links to the abstracts discussed today in the transcript of this episode. Finally, if you value the insights that you hear on the ASCO Daily News Podcast, please take a moment to rate, review, and subscribe wherever you get your podcasts.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.